with you all. I apologize that I'm not in the flesh, but I think we're at a very interesting moment in the history of biomedical research. On the one hand, we have the huge benefit that we have from the Human Genome Project and being able to link medicine to genomics. But there's a paradox that has arisen, which is that we have a lot of detail on the genetics and individual variation, but we've actually done a relatively poor job of linking these genetics to what's actually going on clinically with individuals. So for example, in the genome-wide association studies that you may have heard a lot about, they describe an association with autism or with diabetes. But those of us who are clinicians, or those of us who are patients, know that it's not diabetes, it's not autism. There are very many different diseases that are immersed in this simple label. So in autism, you can have an individual who is unable to speak, who has seizures, who is really not participating in the broad human interaction experience. You can also have someone with the diagnosis of autism who is very articulate, high functioning, even one of your faculty. And yet, in an association study, they're treated as if they're the same category. So is it surprising that we find associations that are not reproducible or that are weak? And of course, we would laugh today if we would do an association study with a genetic association study with cardiac disease, in which we lump together all heart failure due to atherosclerosis, due to infection, due to valvular disease. But in fact, that's what would have the heart failure diagnosis have comprised 150 years ago. And today, many of our common diseases still have that monolithic structure. But clinicians, experienced epidemiologists can go deeper and sort out these different parts. And of course, I should say, parents of children who are affected and patients, adult and pediatric, know for themselves through bitter experience that these are very different subgroups. And so we've worked hard on our side of the Atlantic to use electronic health records and claims data to try to use these clinical characterizations to piece apart the phenotypes of these populations and to go deep. But I have to say we're very envious of what you have in your country, because those databases I referred to are very incomplete. The electronic health record just reflects those hospitals and not where other hospitals where the patient had been at. The claims data only reflects the few years that a patient was with a particular employer using a certain insurance company. So what you've managed to do is to assemble data to allow you to uniquely, in my mind, or maybe out of a handful of countries, certainly not the United States, follow patients longitudinally and able to dissect these different trajectories of clinical manifestations, both deeply into their characteristics and broadly across multiple diseases. And I would say that it's not only scientifically valuable, but it's in the public good. The greatest danger to our citizens is that in the spirit of genetic reductionism, we overtest them, overtreat them to their harm, take pieces of their body out for bad biomarkers because we have not done that deep phenotyping to understand really what are the clinical implications. And so therefore, I'm extremely excited about the opportunity to collaborate with you and your researchers. And I hope you'll be equally enthusiastic about our collaboration to look, for example, at what are the early warning trajectories of diseases like autism or psychoses, because that's something that will allow us to both understand the science underlying these diseases, but also to intervene early in these patients. And so if I were a patient, as I have often been, or if I were a citizen, as I always am, I would want people who have my best outcomes at heart to be able to deeply phenotype me and people like me so that we can actually correctly identify which are the likely things to happen to me and which are the best medications to use for me. And it's only by using these extraordinary resources that you and your country have been able to develop that I think we can do this successfully. So count me as enthusiastic.
I'm happy to hear that, and I think what we have done in the Nordic countries is, as you say, we have been able to follow people from before birth and their family, and with education, welfare, and health data all linked together over a life course. But I think what we really would like to do now is get a deeper phenotype linked to day-to-day living, which is actually what we can do by 24/7 data. And I think what's interesting here is that if you can get this integrated, so the citizen would trust the system and would say, well, actually, I got a very coherent and individualized treatment or support in the situation I was kind of challenged. Then we hope that the citizen would trust more in a public organized system than in Google, Apple, Facebook, and Amazon, which we, from a European point of view, believe could actually have an enormous impact in the way we see health in the future. What do you think about that? Is that something that you can see yourself in, or is it the same situation in the US?
Yes. So on the one hand, let me first address an opportunity and a challenge. The opportunity is that whereas doctor visits are rare and episodic, our physiology goes on all the time. So if you want to know blood pressure, measuring your blood pressure once a year in the doctor's office is useless. Now we have cheap devices that allow us to measure blood pressure many times a week or every day. We manage heart failure by, again, having maybe a doctor visit a month, but just by looking at how you weigh on your scale every day can allow us to better manage your heart failure. People wait for months to look at outcomes for Parkinson's disease, but if you're able to measure through an accelerometer that you wear on your wrist just how much you're walking and what the style of walking that you have is, you can actually detect response to drugs in Parkinsonism within days and not months. This accelerates our ability to take care of you or ourselves. It accelerates our ability to actually discover whether drugs are efficacious or not. So that's the opportunity. The challenge has been, certainly in the United States, is that the worlds of clinical medicine and the worlds of at-home measurement are separate. And so linking them would be the most powerful thing, obviously, but that linkage almost never happens. There is no question that Google, Facebook are gathering huge amounts of data on us, mostly to be able to place ads ever more carefully for us. And even if they are well motivated, taking care of our health is probably not job number one. And so I think, again, you are in a very interesting position where your public health authorities can actually be the honest broker for these data, where the top goal is actually not anything else but population health, and that the data is not reshared for other purposes such as advertisement or selling, so that you can actually take this incredibly useful data that's gathered every day and marry it to the clinical data, which is also incredibly important, but it's also much more episodic and infrequent. That joining is enormously powerful. And because of the longitudinality that you have on the clinical record, putting in a link to the high intensity home data, I think could be transformational for a lot of disease management and diagnosis, and even for running trials. And the ability to do this under the auspices of a public health goal, I think, is not only at this point popular in the Nordic countries, but I could tell you that based on a variety of polls in the United States, most U.S. citizens would much rather have the public authorities do this rather than one of these data companies. Now, some companies like Apple actually have taken an interesting tack where they said, we're going to use the patient as the locus of control of their health data. And so what you're seeing in the iOS operating system is the ability to suck in data from multiple electronic health records for that patient and add to it the everyday data. So they're going to create an ecosystem that is actually controlled by the patient, not resold to anybody else. And I think they turning it into a marketing advantage that they're not going to resell it, not going to use it for anything, except you're going to be able to choose which apps will interact with your data or to whom you wish to redistribute data. So I think it's an interesting market model that's different from the Facebook, Google model.
Yeah, I agree with you, and it's really interesting to find out where is the major value creation for the citizen, because as we see it is, if you can kind of get value creation for the citizen, bringing these data together, supporting their life, you might come up with a population test lab where any health solution could be tested, and which I think is also important from a scientific point of view. I mean, you would have an infrastructure platform that would kind of be able to test any combination of treatments in a population setup where it's integrated around people's own life. And I think this is actually where Apple could be very nice. I mean, some of us use Apple, and Apple users would be welcome here. But I think the most important thing is that bringing all the data together and where that should be in a trusted third-party environment that kind of should be linked to the public area as we see it. But of course, I know with the US and Denmark, we have a bit different approaches to that. Even after Bernie Sanders, I was quite surprised by he actually thought about bringing this forward in the US. So who knows? I mean, maybe in 10, 20 years, we would have this situation in a broader national context.
Right. But you raise a really interesting point, which is a lot of us have been envious that the big data companies are able to, with their millions of users, to do what we call A/B testing, which is another way of saying randomized controlled trials. They're able to say, okay, we're going to throw this user interface or that user interface and see which is more effective in getting people to respond to ads. It'd be great to be able to do the same thing, but instead of saying respond to ads, say this treatment or that treatment, who's going to have higher quality of life. And I think that's incumbent on us to go into 21st century medicine with that as a goal, that we are always experimenting to improve care, as opposed to having experiments be the exception, to have these experiments be the way we're taking care of patients. Every patient continues to be part of the experiment.
That sounds, I certainly agree. And what we hope from the small country point of view is that we can attract, high-level scientists as you to work on this infrastructure. I think that'll be excellent from a research point of view. So we hope we're able to move this forward with your advice, and hope you will come and visit us in Denmark at a certain point.
Well, I am looking forward. I've always wanted to. My children were a bit young, but now I think within a year they'll be the right age. It would be both professionally and personally a great pleasure to come. And I can tell you that I think your healthcare system and your country will sort of punch above its weight, as Americans say, because by having this existing investment, you're going to be able to do things that many of us are hoping to do, but 10, 20 years in the future.
Yeah. Thanks very much, Zach, and I'll try to put this forward on the meeting, and I think it was brilliant. So